All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. This is a special show that we are doing at 11 a.m. because with us we have another rock star. You have seen him before with FLCCC's talks. Today he is with us as well. He is Dr. Professor Eli Schwartz from Israel. He has very recently published a study, and we wanted to talk more about that. So Dr. Schwartz, Professor Schwartz, welcome.
Welcome to you too, to all the audience.
Thank you very much. So I'm very quickly going to introduce you, and then we will start having our discussions. So give me 1 second. I'm going to show your bio. So here we have Professor Eli Schwartz, MD, DTMH, the founder of the Center of Geographic Medicine and Tropical Disease at Sheba Medical Center, Tel Hashomer, Israel. I think I can pronounce Israel very well. Full professor, clinical at Sackler School of Medicine, Tel Aviv University, head of the molecular lab for tropical diseases at Sheba Medical Center, the president of the Israeli Society of Parasitology and Tropical Diseases, the past president of the Asia Pacific Travel Health APTH Society. He is deeply involved in tropical and travel medicine since last 30 years. He has published several books and more than 250 articles and chapters in the medical literature on travel and tropical disease, which is awesome. And now for us, fortunately, he's now focused on corona as well. So consultant physician for the Ministry of Foreign Affairs, head of the task team for evaluating therapeutic options for COVID-19, evaluating new methods for diagnosis of COVID-19. So with this introduction, I'm going to go back to Professor Schwartz. And so once again, welcome. Please tell us a little bit, what are your day-to-day activities nowadays in the pandemic? How is the pandemic? How is the disease? Is it finished? Is it still there? How was it? Can you tell us a little bit of your activities?
So again, my main activity before the corona is, as you mentioned before, is tropical diseases. Parasitology, tropical diseases, and I think it's deeply connected to the story of Ivermectin, because what's happened in Israel that many physicians never heard even about the drug, and I guess in many other Western countries is the same situation. However, because we are dealing with tropical diseases, that some of them Ivermectin is a needed drug, we were aware of this properties, and we know about the safety profile of the drug, and therefore we decided to go for it to do the study. Meanwhile, the corona hit Israel very badly, and fortunately we were the first to get enough vaccine, and we have the capacity. I would say the health services in Israel are really, the public health services are really excellent, and they were well designed to distribute the vaccine. And therefore, upon starting it in the late December of 2020, within a few months, we succeeded to cover almost the entire country, talking about the adult population. And just now, we starting to vaccinate the younger, 12 years old and older. So basically, what's happened after a few months of vaccine campaign, it's really dramatically changed the epidemiology, and we actually don't see now or hardly see any case of corona these days. The good news is that everything is almost open in Israel, and just last week, we got the official permission not to use the mask. So we are not need anymore, even in the public domain or going into stores, shops, etc., to use it. Only with patients in hospital, we still using it. So basically, I would say that daily engagement with corona patients is almost cannot be done these days in Israel. We certainly dealing with the vaccine, with the impact of vaccine, the effectiveness of the vaccine, durability of antibodies, etc., which I don't think it's part of the discussion this evening.
So thank you very much for this. Actually, if you don't mind, there are some burning questions about vaccination, and Israel has done a great job of vaccinating a larger population very quickly. If you don't mind, can I ask you some questions, even if just from you being there? For example, and please don't mind if they don't look the best questions, there has been a question about um, vaccine, especially Pfizer vaccine. There is a study from Japan, and so there is a concern that Pfizer vaccine would end up causing spike proteins in the ovaries and then cause menstrual irregularities and possibly infertility. Have you seen any such evidence in this large population that it causes fertility issues?
No, and actually in Israel we're using only the Pfizer vaccine, and I think we were lucky to have it because the effectiveness is probably the highest comparing it to the other vaccine. When I say the highest is Moderna, and Pfizer probably should be the same, but this new method, it's really uh, proved itself as being a highly, highly effective vaccine. So that's one point. The second point, that any significant side effect, I would say we don't see, especially not any infertility problem, neither in males, not nor in females. And just today, there was a paper in the New England Journal of Medicine, again, about pregnancy, the impact of the vaccine, Pfizer vaccine on pregnancy, and nothing was found, although the number were quite small. But also in Israel, I mean, we don't have any impact on it. And on the other hand, we saw the devastating impact of the disease itself on pregnant women, with a few death cases of young pregnant ladies. So I would say, if people ask me if to go and take it, obviously yes.
Okay. So then one more question. There is a question which is very commonly asked and is published and promoted, and that is that if somebody who does not have a vaccine yet and they're closer to a person who is vaccinated person is going to cause shedding and make the unvaccinated ill, and in case of women cause them to have miscarriage. I know that majority of Israeli population is now vaccinated, but was there any such time where you observed any such vaccine and non-vaccine interaction and issues?
No, I mean, there was a lot of interaction between people who were vaccinated and non-vaccinated, and we still have it because, young children, for example, are non-vaccinated. If I understand well, correctly, the question, it's maybe, can a vaccinated person still transmit a disease? Can be asymptomatic, but maybe still harbor the virus and can transmit it to the non-vaccinated person. I would say that despite the knowledge that we are gaining every day from on the vaccine impact, for this we don't have an absolute answer. It seems to be that the fear that vaccinated people still can infect others, it's probably almost nil or nil. Despite the fact, and the interesting point is that despite the fact is that we know that there are several people who were fully vaccinated and got ill. It seems to be, and this is, I'm saying, preliminary results. If you do culture viability, we will talk later on, I guess, about culture viability also in the study of ivermectin, but culture viability seems to be the best surrogate marker for infectivity. If the virus can survive, can proliferate in the culture, it means he can infect the others. So it seems to be that people who are vaccinated, the chance that the virus will grow in the culture is probably almost nil. So this is, again, small numbers, but it gives more confidence that people who are vaccinated, even if they are sick, they still cannot infect others.
Got it. And just a related question. So there are shapes of this question. So there is one more shape, and that is that some people believe that once we receive the vaccine in our deltoid muscle and the spike proteins are produced there, somehow they would end up in the throat area, and those spike proteins will shed as well, and they would cause damage. Is there some possibility you've seen any evidence of
No,
this?
no, and you cannot be sick from the spike protein. You need the whole virus. So even if the spike protein somehow is excreted outside, it cannot cause a disease.
Got it. And one more question. I know that we're going to go to ivermectin questions in a second.
Oh,
There has
vaccine is a good topic.
Okay, excellent. Thank you very much. Because these are the questions that have been here, and I handle them, I receive them, but listening from someone who is there is more important. Um, the the cardiotoxicity or cardiac inflammation in youngsters. Two youngsters, youth died as well. Uh, do we know more why this is happening? Has that information or knowledge that vaccine may be causing pericarditis or endocarditis or myocarditis? And has there been any change in the practice of administering vaccine?
That's a good question. I mean, there's no doubt now that probably the vaccine may cause myocarditis or pericarditis, and in case I don't know who is listening to us, but myocarditis is inflammation of the muscle of the heart, and pericarditis is a kind of the surface of the membrane which cover the heart. It's probably may cause it mainly in young males. It's not in the elderly. It's happened in the more youngster, 20, 30 years old. People may look at it maybe of kind of autoimmune disease, maybe triggering autoimmune response to the vaccine. And again, I'm saying now something which is my personal belief, that maybe if you have high level of antibodies after, and the other point, just a minute, is that it's usually happened after the second dose, not after the first dose. And my feeling is, or it was trying it, is to open the lag period between the two doses. I mean, Pfizer tried to emphasize that it's highly important to get it after 3 weeks. It's totally wrong. I mean, just talking about all kind of vaccine, one should remember, if you try to shorten the interval between two doses, it might not be effective or maybe side effects. If you open the leg and you delay the second dose, it will be the same. You will get same effectiveness. And here maybe we may get less of this specific side effect. That's interesting to try to look for it. And again, this is my personal inspection.
This is actually a very interesting comment, because we can take this comment as a hypothesis and test it in UK, where they had actually increased the gap between the two doses. So I'll do some research, but that's a very interesting comment. I have one more follow-up on this one.
But this is a good point which you raised. Maybe we have to see the level of myocarditis which reported in UK compared to the other places like US or Israel, when the two doses were strictly given.
Correct, because they have gone to 84 days gap. So it will be interesting to see. One more question that I have on the same topic. You or your colleagues, was this ever found that this may be because of the vaccine, or is it still a position that, hey, other youth would get similar rate of the disease and this may be here? Meaning, is there any association confirmed, or it is still under investigation?
Association between what?
The vaccine and the some youth having myocarditis.
Yeah. It seems to be that it's the vaccine effect. That's quite sure. Okay. But again, I mean, the percentage is very, very low.
It's very low.
So if people ask me, being in a situation of pandemic, so devastating epidemic, pandemic, and we have to pay the price, let's call it, that few people will get myocarditis, which in almost all it was reversible after a few days, I would say it's still go for the vaccine.
Got it. So then another question about the management in pregnant women. This is a question that is very common for me, and very often the cool beans know here, the community knows here, I avoid that question because I'm very careful for pregnant women or for children. I'm going to ask you a few more questions for the vaccine still. So first one, pregnant women, did Israel administer vaccine when the women were pregnant, or this was contraindicated during that time?
No, no. I mean, at the moment that the vaccine was available and we started to see, I mean, at the beginning, there was some hesitation whether to try to wait until the third trimester or even after delivery. But when we started to, I mean, the vaccine arrived, reached Israel in the third wave, which was the highest and the worst we ever had, including death cases of young pregnant women. And therefore, the recommendation was just to get it.
Got it. And then one more question, and this is more sensitive for me as well and for others too, and that is children. So people say this, that children are usually uh, better at handling COVID. And so why to expose children from 12 years to 18 years? Again, I know that you're not the policymaker on it, but you're a big influence as well. Uh,
Yeah.
How do you see children getting vaccinated?
So again, this is a debate also in Israel, and we have, and it's not between, the lay people and the physicians, it's also among the physicians. I would say, based on my experience with vaccinology and giving vaccines to children, to adult, many vaccines we are giving for travel purposes, I would say that children are not more susceptible to any side effect than adult. That's to start with. And the efficacy of the vaccine is very high in children compared, as we know, in the adults. So this is another starting point. And now let's go to the claim that actually the disease is nothing among children. And I think this is totally wrong. It's totally wrong because the statistic mentioned that about 1 in 1,000 going to have a severe disease. Severe disease is hospitalization or even death. If you take Israel, for example, with about 2 million kids, in 1 in 1,000 will be severely sick, it means we're going in 1 year to lose maybe or severely disease of 2,000 pediatric population. This is unacceptable. For other diseases like measles, like hepatitis A, for example, we gave mass vaccination. So I think that this is a good reason to vaccinate the children, taking into account that even with less severe disease, we know now that long COVID may happen also in children. So you have again another disease which might be chronic disease for months or who knows for how long, and you want to avoid it. Now, the other point which is more relevant to Israel, people say in Israel, physicians say in Israel, now we don't have, I mean, it seems that the virus is almost non-circulating in Israel. So why to vaccinate them? But the Israeli like to travel. And the world is open for us more and more, and people like to go there. So if you are not traveling next month, you are going to do it next year. And the globe is a small village, we know it. So since the pandemic still is circulating in the world, all these reasons, I think I strongly suggest to get the vaccine. And again, we don't see really any side effect of it, any significant side effects. So the fear that maybe, a tail will grow for a child after 10 years, or it's nonsense. And actually, it's never done for any other vaccine. We did not wait so many years, one generation, to see that everything is fine. So taking all these circumstances, I think that it is highly, in my view, it's highly recommended to take it.
Got it. So some more question for vaccine. The variant. So nowadays we have this Delta variant. Before that we had the Alpha variant or the 117 from UK. Then the African, I think that was Gamma. So let's say the society is primarily vaccinated. The coronavirus is not circulating that much, but there still is travel. Has Delta variant arrived and caused reinfections?
I mean, there are 2 points here. One is that the Delta arrived to Israel, but we don't have it in high numbers. Like the British variant is already almost totally covered Israel. But the Indian and the Delta, we have few cases, but it's not a massive around Israel. So far, and now the other question is, do we really understand what is causing reinfection? And actually, we don't have good answer. We try to do some systematic review on the cases that worldwide reported cases. And it seems to be, we thought that maybe some people don't develop after disease or after vaccine, they don't develop immunity. And there are those who are susceptible to get reinfection. But in fact, we found also people who did develop immunity, measurement of antibodies, and despite it, they got the disease. So it's not really clear, and even we can't blame the variants. For sure, if you have variants, it may cause it also, but we cannot blame, because even before the variants arrived to several countries, we still had reinfection. So I would say the whole story of reinfection or getting disease after being fully vaccinated, it's still not completely understood.
Got it. So then
altogether, I want maybe some optimistic view. Again, in my view, there's a lot of talk in Israel and a lot of talk in the world about the variants that it's going to cause catastrophe, etc. I think the chance that, again, based on what I know about vaccines, the chance that a virus will escape a vaccine, efficacious vaccine, actually has never happened in the history. We have vaccine like, again, travel medicine used yellow fever vaccine. We are using yellow fever vaccine for almost 100 years. And we still don't have any variant which escaped the vaccine. Same with the MMR, with the measles. So I think that we are causing too much fear, and we have to really prove that we found a variant which actually overcome the vaccine. Until we have a good proof, people can sleep nicely at home and be relaxed. That probably is not going to happen.
Absolutely. And my own opinion here, I also believe two things. Number one, variants are usually, when they're becoming more efficient, I feel they are becoming less damaging as well, because they want to go into more people. And so they can only survive in more people if they are not causing too much damage. But we'll see as UK's cases rise. My interest was very much, and you responded to it, to see if Israel has this variant has broken through the Israel's vaccinated community. One more question that has been very common. These may not be scientifically very solid questions, but because they are present in the society globally, it is interesting to ask them. One more question is that some folks have been saying that if somebody gets vaccinated, let's say I am vaccinated, then somehow vaccine generated immunity will cause my innate immunity, that is macrophages and neutrophils and NK cells and dendritic cell, to be not responsive correctly or not to be able to work correctly. So when I, who is vaccinated, will get the actual infection, I will be destroyed. My immune system would not be able to work, and I would get a lot of infections and I might die. Have you seen any such evidence in the Israeli society?
I heard such rumors, and I think it's anti-logic. I mean, the whole point of vaccine is to mimic the disease. So if you get the disease, your immune system is created to fight the disease, and what you want by vaccine is actually to have the same fight, to create the same antibodies, but without being sick. And this is the whole story of vaccines from the beginning of the history of vaccination. And therefore, to say that the immune system somehow is become defected by the vaccine, I think is illogic and not correct.
Got it. So again, we had not rehearsed this answer, but I have been saying the same thing, that from an immunology mechanism, there is no known mechanism where when adaptive arm becomes active, it will cause innate arm to become damaged. So tell me this, I have this Israel's number of cases over here. And if you see here, no new cases. You said that society is open as well. At this time, at the most, there are 231 currently infected. there are still some deaths which may have been trailing. So, how is Israel now managing its travel? Meaning, Israel's society itself is now comfortable. How are people who are coming in? How do you protect from further variants or infections to come in? Or you feel that because people are vaccinated, it does not matter anymore? What is the policy?
No, I would say the main the feeling in Israel is much more. The atmosphere is calm. We don't feel the threat of the disease, but everybody is afraid that the airport, Israel is like an island from this point of view,
Hmm.
because all the borders are closed beside the sea, and we have the airport which is open. And really, the fear is that people around the world who wish to come, or Israeli who wants to come back and coming from a highly endemic area, will bring with them the variants or significant variants, and may bring somehow a new variants to the community. And we have to remember, still, children are not immunized, which in Israel, the percentage of children in the Israeli population is very high. So first of all, you have a significant number of people who are non-vaccinated. And second is the fear that we discussed before, that maybe a special variant will come and overcome the vaccine. So the policy is to try to isolate those people who are, even if they are vaccinated, if they're coming for specific risky area like India, for example, to isolate them despite having the vaccine or antibodies testing. But within the country, I would say it's much more relaxed.
Got it. And congratulations for being a society who that has taken care of the people very quickly. I loved it, and I appreciated this about Israel, that they struck a deal with Pfizer to say, you give us priority on the vaccination, and we will give you data which would help for the rest of the world as well. So that was a very smart move. So congratulations on that. So if you are ready, can we ask some questions about your ivermectin study that came out from your team as well? So I'm going to quickly share the study itself. So Cool Beans, please hold on to your questions for a few more minutes. I want to make sure that we get these studies and the data in front of us, and then we can ask questions too. And when you get ready for the questions, please put some QQQ with the questions. So I have the comments here. I can just go through the comments and figure out where the questions are. Okay, so here is this study. This is the study by Dr. Schwartz and his team, his colleagues. So here, favorable outcome on viral load and culture viability using ivermectin in early treatment of non-hospitalized patients with mild COVID-19. It is a double-blind, randomized, placebo-controlled trial. Some people have said it is small. Why not we actually speak with Dr. Schwartz? And so, Dr. Schwartz, what do you think about this study? How do you feel about it?
First, I can tell the history of the study. I mean, as I told you before, I was appointed to try to find any kind of medication which may help the epidemic. And the way to look for it was to find a repurposing drug, because to try to create a new one, nobody think it's going to help in a short time. And at that time, the first wave of the disease, if you remember, everybody was looking for the hydroxychloroquine. This was the type of messiah, and everybody was doing we heard first experiments from France, and everybody, I would say in every country, including Israel, they decided to do their own study on hydroxychloroquine. So I didn't want to go to a niche where everybody else is already there. And based on my experience with the drug, knowing the safety profile of the drug, and having the Australian also, we knew also that the drug considered to have antiviral properties. And there was a pre-publication from Australia showing in vitro activity of the drug against the SARS-CoV-2. So we decided to go for the ivermectin. So the decision to do it was on April, and it took a while to get all permissions, the ethical committee, etc. And toward the end of May, we started the study. I want to say that I knew the drug, I know the safety profile, but I had no any clue whether it's going really to help in corona or not. And therefore, it was really, when I say that double blind, it's not that, sometimes you have a hypothesis. We didn't have any hypothesis. We wanted to check whether it can be a good drug. And I would say, we said to ourselves, if it will prove to be good, everybody will be happy. If it will be proved to be non-effective, so we have to know and to tell the people, don't go in this way, try to find another way. It took a long time for the study. The sample size calculation that we made told us that we need about 90 patients. And to recruit these 90 patients, despite the fact or in time that we have, waves of corona, that we have 10,000 patients diagnosed per day. And with all these high numbers, to recruit 90 patients took for us almost a year. So it was really hard. And again, there was no any funding. The Ministry of Health did not want to fund us, nobody else. And I think part of the story is that maybe repurposing drug is nice to shout about, but somehow societies, authorities don't want to put money in it because somehow it's less attractive. It's much nicer to create your own new medication or new drug. And so that was the beginning. And only when we opened it at the end of the study, and we started to see that actually there's a favorable outcome. So if you ask me today, what do I think about ivermectin? Does it have any impact on the virus? I would say definitely yes, based on our study. And I think, for example, the culture viability, which I think we are the first to publish it in the world, to look in this way, it actually says that ivermectin sterilized the cultures. So it's a direct proof that it has anti-SARS-CoV-2 effect. So basically, we saw that the viral load is going lower much quickly in the ivermectin group, and it sterilized the culture. Both of them actually means that transmission chain can be broken by the drug, and that actually was the purpose of our study. We did not look, for example, deterioration of severe cases to if we can prevent hospitalization. We did not look whether it's good for prophylaxis. It's all kind of different studies. But to see whether if you give it at the beginning of the early start of the disease, you give few days of the medication and you can change the course of the disease, that was our purpose. And we will discuss later on that I think part of the conclusion that we may have here is that we can shorten isolation. And isolation time was a major burden on living during the pandemic. So I'm emphasizing all of this because people ask, what's the point? I mean, our patients were relatively mild patients because they were not hospitalized. So what's the point if you shorten the disease of this mild patient? I mean, if you save life, that's something. So don't forget, I tell the people, don't forget, 95% of all the COVID population, the COVID patients are mild cases. And if you can change the natural course of the disease, again, for the public health, you did a lot, and also for the people. I mean, instead of being sick for 2 weeks, if you can be sick only a few days, it's also some kind of change.
Got it. So one more question, and let me just very quickly show this to the audience as well. So Cool Beans, this is the PDF of the study. I had actually gone through this PDF with you in another video, and I think somewhere here there will be highlights of this as well. So as you can see here, I've highlighted various parts, and we have gone through this study in the past. I'm going to ask one more question, Dr. Schwartz. With this study, so we're going to talk about some of the criticism or the questions, but I want to understand, with this study, within your own work, what is the change that has appeared? Have you started using ivermectin? You don't need it because the disease is gone. Do you now tell people that, hey, it is a useful drug? So what is the change, if at all, from this study?
The change which happened to me when we opened, I mean, it took time from opening the codes and until publication. But when we open it, we notice that there's no doubt that the ivermectin has an impact. And therefore, when people contact me, and many people by looking into the NIH clinical trial site, they found that even in Israel, they are doing study on ivermectin. They contacted me, and people wanted the drug. So everybody who wants it, I say, look, we don't have fully confirmed results yet, but it seems to be that first, it does not harm you and may help. And therefore, I much more easily, I gave this drug to people who ask it. These days that we don't have acute cases, it's good for us, but we have unfortunately, we have the long COVID. And since there are also reports about the impact of long COVID, of the drug on long COVID, I also start trying to give it to people who are asking me about it. But again, at some point, we have to do, a scientific study on it. But so far, if you're asking what's the impact, I'm much more relaxed. And to give it, I feel easy to give it to people who seems to need it.
Got it. And this is a very important point, that to figure out that here is a study and here is some data, and then based on that data, you can say, all right, I know I can stand behind this drug, and it's not just some people made up some statements. So thank you for doing this. Related question: if we take the study to, of course, there are some questions that are still going on for the document itself study. But if we take the study to WHOs or US's CDC or FDA's, they would say it is too small. There are some cycle threshold things and others. How do you assess your own study to say, does it rise up to a merit where people should look at it and understand that, hey, it is valuable information here, and based on that, our practice for early treatment should change? Or you feel that there is still more data to be collected?
I would say, first of all, I mean, the study was well done according to the Western style, and I'm saying it because one of the main criticism of WHO, NIH, etc., is that in many low income countries, low medium income countries, where the drug is much more available, the studies which were done there will not, adherent to the scientific measurements that we want to take. For example, you don't have placebo; it's more kind of observation, or you just take the standard of care and compare it to medication, which it's open the way for kind of bias. So here is, I would say, we try to be very strict. Now, people used to say, it's only 90 cases, so it's a small amount. But again, I mean, in statistics, you have sample size. This exactly you do sample size calculation. And especially that, it's done without any funding. So you don't want, you can't waste your energy and time too much. But it was based on the sample calculation. So if people say it's not enough for us one study, and we know that sometimes, one study, good study, say this one, and the other study may show different results, go ahead and do it. But I think the situation today is that the major authorities, the big authorities, they are, objecting the data, but they don't try to push for it. And I think our study is definitely a good study, which should encourage them to continue and search for other aspects of ivermectin. They can repeat the same study as we did. They can do it for prophylaxis. They can do it for, prevention of deterioration of the severely sick patient. It doesn't seem to happen. And actually, I want to say something more. One of the main opponents against using ivermectin is Merck, the company of Merck. And they're going with a new drug.
Molnupiravir,
Yeah, and
which is RDRP blocker.
they published the pre-publication report, and actually they did the same style of study that I did. They took mild cases, they look for viral load, and they look for culture viability. So they are just mimicking the same, and they don't try to take the old and cheap drug and to do the same.
And they have already gotten $1.2 billion purchase order from the US government. So thank you very much for this. One more question before we continue to look at the study. Some folks think that the world is so black and white that it is either vaccine or ivermectin, or either just the ivermectin and no vaccine. I feel that they can be combined. How do a person who is vaccinated, can they still take ivermectin? Can a person who is on ivermectin then get vaccinated? Is there any exclusion that they should not be given together?
It's an important question, because I also got the feeling that many opponents of the vaccine, and there's a big group of opponents for the vaccine, they try to rely on ivermectin. That's going to be the savior. I don't want the vaccine, I want the drug. So, again, my opinion about it, vaccine is vaccine and drug is drug. There are two different purposes. And if you ask which is the best way to prevent disease, no doubt the vaccine. There's no anything else which will be as efficient as vaccine, especially after we know the high efficacy of this vaccine. So the purpose of the drug is actually to treat early disease, and as I mentioned, to reduce the time of isolation. So think about society in a country that instead of being in quarantine now for 2 weeks, that's 3 days at home. Sorry, 3 days at home, and then they can go out. That's a major change. It should be used for high-risk group to prevent hospitalization. And we know that in many countries, the burden on hospital was too high. I mean, people cannot get a bed in the hospital. So if we have a cheap, easy drug to give them and to prevent hospitalization, is excellent. The other point is, if you don't have vaccine, and again, Israel is a lucky country that we got early the vaccine. Most of the world are not there, and most of the world going to get the vaccine in few years more. So since from now until they be fully vaccinated, many people will be sick. Now, for example, you may use it, as we mentioned before, for prophylaxis. So if you have somebody at home who was diagnosed as being sick, and all the rest of the family will take a few doses of the drug and you prevent it, that's excellent. So again, it's not for the long run, it's not instead of vaccine, but there are many ways, good ways, important ways to use the drug to prevent the spread of the disease in the community.
Got it. And one more question now, going back to the study. In terms of dose, what was your comfort level? What dose did you use, and what dose do you recommend now to your patients?
So again, as I told you before, I initiated the study very early at the beginning of the epidemic. Nobody has any clue what should be the dose, but I knew that we are using usually for 1 day or 2 days, and I decided that it's better to have slightly higher dose. I was very cautious about it. So therefore, instead of giving 2 days, which was part of the policy in my daily life in the tropical area, I decided to give 3 days, and especially that I found there was a study on dengue, which they tried to use the ivermectin to see whether it's changed the symptoms and viral load, and they used also 3 days. So I must say that I have, a lot of abdominal pain, let's call it. I was very worried about increasing the dose. Nobody really knew about the safety of it. So therefore, we decided for 3 days. Today, it seems to be that maybe 3 days is not enough. So part of the further studies which needed to be done, that maybe to increase the dose. All this should be further explored, and unfortunately, we don't see it done very quickly.
Got it. And the dose that you were using was that,
0.2 milligram per kilo.
yes, I see it here. So the cool beans who are asking this question, this dose is in the study as well. Cool. So now let's talk about one more thing. There are some questions. For example, here there is a very good Redditor friend who has put those questions, found them from various areas and put them together. Just a couple of questions to give you an idea of the kind of questions that are being asked. So one question, for example, here, the viral load at day 0 is already higher in placebo. CT is lower with p-value 0.1, which is also almost significant. So I think there is one that, hey, placebo was already higher load, so it would give you good results anyways. Is that so? Tell me a little bit about the CT value decisions and how was that done?
No, so again, I want to remind you, it was completely double blind. So it's mean people, the way it was done, people who, in Israel, there was dedicated hotels for people who found to be positive and they could not stay at home because there was no enough facility for isolation and they were not sick enough to be hospitalized. So Israel, the Ministry of Health opened hotels where these people were allocated. So we decided to go there and try to recruit the patients there instead of running from one house to another house to find patients. So just for our convenience, it was done there. Now, theoretically, everybody who was admitted to the hotel supposed to be positive, and we contact them by telephone, and we told them about the study, whether they want to participate or not. And all those who say yes, we send a physician. They have to write informed consent, to sign informed consent, and then we took another sample, which is the 0 sample for us, and we gave them the medications. So we didn't have any clue what's going to be the CT value of this sample. And we didn't know whether the patient was given placebo or ivermectin. So only at the end, we found it. And what's happened, this is double blind, that when you open, you expect that actually all parameters will be more or less the same in the two groups. And again, if you look in table 1 in this study, when you look to the age of the patient, if you look the number of symptomatic versus non-symptomatic, percentage of female, and CT value, nothing was significant, including, despite this difference, it was non-significant. Here, this is the first one, and you see the last part is the CT value on day 0, and you see that the p-value is 0.1, similar to the other. So that gave us confidence that really we have balance in these two groups.
Got it. So then one more question. Differences in day 2 and 4 look more pronounced visually, but only a subset of patients got the additional swabs at days 2 and 4, and we don't see day 0 values for this subset only, as is only part 0 plot for all patients together. So I'm going to just open figure 2. So there is some, where is figure 2? Just one second. So these are tables, figure 2. So there is some questions around figure 2 and the difference at day 2 and 4.
Yeah. So again, the story is, as I told you, we started it in the first wave of the disease. At that time, the policy of Israel, and I think policy all over the world, was that people who are sick has to be isolated for 14 days. And only after 14 days, they were allowed to start having a nasopharyngeal swab testing and waiting for 2 negative results until they will be released from the isolation. So following this, we thought that if we give the patient for 3 days, and then on day 6, we do the first examination, the first PCR examination, and we will find that really on day 6 they are doing better, it will be big change. Instead of staying in the hotel at least 14 days, actually, in fact, after waiting for 2 consecutive negative results took almost 1 month. So doing it and finding that on the day 6 there is a big advantage of ivermectin, we thought it's good enough, and therefore we declared as the primary outcome that we are looking for. However, in the middle of the study, at the beginning of September, if you remember, in many places in the world, many countries, including Israel, they have decided that there is no need for this 14 days isolation, there is no need for 2 sample examinations. If you are 10 days from symptom onset and no any more symptoms, you can go home without any testing. So the whole study has to be shifted from 14 days. Everything was ended at day 10. And then having only day 6 as a parameter, we thought it's not enough. So in the middle of the study, we actually added the 2 more examination dates, the day 2 and day 4, and which I'm sorry, today I'm very sorry that we did not do it from the beginning, because what's happened, you see clearly the advantage of ivermectin. However, this number of patients is much less than that we have. It's not based on the same sample size calculation that was decided at early stage of the study.
Got it. Thank you very much. This was actually a very important point to discuss. Then there is another question. The cultured samples for different days were from the same patients or randomly selected on each day. If the same patient, were there also differences already on day 0 between placebo? So were these samples kind of mixed between the patients randomly, or same patients were?
No, what's happened is that all positive sample was supposed to be in kept in freezer in minus 80, and all those who were CT value above 30, the chance to have any culture viability is almost nil. So they were excluded, and all those below 30, every sample which was found was included. So some of them actually, absolutely, there were people who were positive at the beginning, positive after another test, and only later on become negative. Those who become negative from the beginning, they certainly were excluded. We did not calculate 2 times negative person.
Got it. Thank you very much for that. So what I'm going to do is, my Redditor friends, I have a ton of other questions too, so I'm going to go away. I know there are some points that still need to be answered here. Dr. Schwartz, how are you doing with the time? Are you okay if I ask some more questions?
That's fine.
Okay. So here is our announcement on Twitter about your presence today, and some questions here. I'm going to leave this first question, Sandhya, that is a different topic. Mary says, do you think ivermectin can mitigate the damage being done by spike proteins in the vaccine?
So again, I don't think there is any damage done by the vaccine, neither by the spike protein, but I think that ivermectin has a major contribution to fighting the epidemic.
Got it. Then No Jesus says, is it safe to take ivermectin long-term, and what dose for prophylaxis?
So this is for me, is unanswered question. I mean, now I know that people starting to give it for long day. We have I was in a presentation that I think a French group showed us a study where ivermectin was given for 1 month. The regular dose 0.2, but for or even slightly higher, but for 1 month without any problem. So there are accumulated data which show that you can take it for longer period. I know from people from South America where they use it for prophylaxis, usually they take it once a week. They don't take it daily. So, but again, this is not my own experience.
Got it. So if you don't mind, if I can add my experience. So I have been taking and giving, although since vaccination, my routine has become a little less rigorous. but I have been administering ivermectin 0.2 milligram per kilogram body weight on a weekly basis. And some people have been taking it for about a year now. So again, not a study, but just an experience from one of the doctors. There is a person who is happy about you here. Then here is a question. Can he debunk this question in the comment section of the MedRx? I'll see if I can, if we can make sense of the question. This research is problematic. First, this clinical trial's primary outcome measures were as attached below, and authors did not mention 2 out of 3 primary outcomes. Second, even the primary outcome measure they used was not specified before the study. Authors used CT value of 30, which was arbitrary. Authors explained when they did not use 40, but they must have used 40 if that leads to good results. They did not correct for multiple comparisons across 3 primary endpoints. Second, as the figure 2 and table shows that the CT value of 2 groups before the intervention are close to statistically significant difference, 0.1. So I think you kind of touched upon these before as well, but just wanted
Yeah,
to show
but
you.
I mean the point that he raised about the CT value, again, I don't know how much the people interest to listen about CT value, but I think the whole story of diagnosis it really got a big change during understanding the disease. I mean, I thought at the beginning, for example, that to know whether the patient is sick or not, positive or not, is very simple. It's black and white, and it turned to be completely wrong. It took time to understand it. So, in some countries, for example, the cutoff to say negative is 40. In some countries, the negative is 35. In some, 35 to 40 is considered to be borderline. So each country has a different point of view on this. That's one thing. The second, this is maybe more important, and therefore now we thought maybe 40 will be the cutoff and will be easy to decide. But however, people reaching 40, at least in the laboratory of Israel, about after 3 weeks and more. So, I mean, we don't have, I mean, the number that reached it before were very small. You can't make anything. In addition, the big change, as I told you, was the changing policy of isolation. Instead of checking few times after 2 weeks, they decided that 10 days is enough. Why 10 days were enough? How did it come from? And the answer for it is that they found that usually after 10 days, your CT value is more than 30, and in CT value of more than 30, there is no culture viability. And as we mentioned before, culture viability is the best surrogate marker for infectiousness. And you want to isolate the patient, not because you want him to be isolated, but because you want him not to infect the others. So CT value above 30 become kind of kind of threshold when you know that above it, people are not more harm to the environment. And this is actually the point. This is the main point that we wanted to show, where the ivermectin can make it shorter.
I totally actually agree with this, that a lower CT value, as you said, culture viability is very important. That means there is a virus compared to there is a fragment of the virus. So thank you very much for that clarification. Lee Holloway says, and sorry, I didn't name this person. So here, this question was from Ciudadano Pai. Lee Holloway says, what initial signs and symptoms should be used to commence taking ivermectin? So for example, for your study, you must have decided that here are the signs and symptoms to be called mild, and we would administer this. So what is inclusion for this?
No, again, I want to highlight it. Because our measurements were very solid, we were talking about level of PCR, we were talking about culture viability later on. For us, doesn't matter whether the patient was symptomatic or even asymptomatic. I mean, one of the questions I think was, how come that we have asymptomatic patients? So we did not allocate the patient. Patient was sent to the hotels if they were found to be positive. They were found to be positive either because they have any kind of symptoms, or because somebody in the family was positive, and therefore the whole entire family were checked, and they found some of them to be asymptomatic and positive. So all those who came into the hotel and they were positive not only by the outside laboratory who tested them, but also confirmed by our lab, they were included. So we have all range of symptoms and even about 20% without symptoms. And the range of symptoms are, from cough, fever, but altogether it's not very mild. Actually, we mentioned 3 people, I think, had to be hospitalized. One of them for long period and 2 of them only for short period. The majority were on the placebo arm. But it was not a high number to make any kind of statistic out of it.
Got it. And here is Dr. Yo. Dr. Yo is a very good friend of mine. I think he has interacted with you as well through FLCCC. He sent this. So may the Schwartz be with you. So we have Schwartz with us today. So thank you very much for being here. And then there are some more comments. How is that ivermectin used in treatment of VAX? So I think we'll leave that question. How is that ivermectin used for the long COVID? Then this is somebody who's saying that I used ivermectin for a friend and it worked very well. I want to, if you're okay, how are you doing on time? Can I ask some more questions from the live audience?
Okay.
Okay. So I know it is 10 at night at your place. So it is really late. So Cool Beans, I'm going to ask some of your live questions. If you had written a question before, it must have scrolled up. So I'm going to pick up whatever are the latest. And if you want, please write once more. Let's see. Dr. Amir Hashmi says, can ivermectin be given to the ventilated patients?
So again, I'm familiar with one study actually, which was done in the United States, in Florida. And the drug was given to severe sick patients, even ventilated patients. It was retrospective analysis, kind of observational study, and they claimed that the mortality rate significantly was reduced by using ivermectin.
Got it. Next question is Tom Johnson. They say, then why the risk of using messenger RNA vaccines? Why did they not just take inactivated virus vaccines? No Western pharmaceutical company came out with the one, while we know they're safe and have been used for years.
Yeah, so again, I mean, the Chinese vaccine is based on this method. This is the old method. The mRNA is a new method which seems to be more efficient and much more quick to produce and to change in case you need it. For example, if there will be a new variants, important variants. And in fact, it was great success. I think it's one, for me, it's one of the major step in the history of vaccine in the world.
And I love messenger RNA based vaccines. I loved Novavax, but it was still not available. So I got Moderna, and I'm pretty happy with that one. Julius said, how much did Dr. Bean say so 0.2 milligram per kilogram body weight.
Yeah. And again, this is the typical dosage that we use for parasites. But I know that there are several studies which they use even 1 milligram or even 1.2. This is the higher dose I think I know per day.
Got it. So there is a question from a Cool Bean, Eileen Glazer Miller, a sensitive question. So totally up to you to pass. Thank you for your interview. Very sensitive question. Don't the doctors in Israel work for the government versus their own private practice? Therefore, does the good doctor respond regarding children getting vaxxed because of the government agreement with Pfizer? Clearly more risk when children taking an experimental vax versus COVID risk, and there is early treatment. So are you influenced by some?
I think usually I'm not influenced by others. I try to get my own opinion. And again, I think my own experience is really dealing a lot with vaccine. My daily life before the corona was vaccines. And many people who dealing today with the corona vaccine don't have any previous exposure to vaccines or to daily practice of vaccine. And again, I think it's a good vaccine. Side effects are minor. especially if you talk about a situation of pandemic. And therefore, I think that, and children, I think, need it. As many other diseases, usually we start even with children. So the fact that they are slightly less or less having severe disease, as we discussed before, it's not a good reason not to vaccinate. I think it's important for them, and especially in Israel, as I mentioned before, families like to travel abroad, and abroad means you are going to endemic area. In Israel now is safe, but outside you will be expose yourself to the disease.
Got it. Bo says, is the first few days after getting the first vaccine dose, the person becomes vulnerable? And if someone gets COVID at this time, it may be more severe. Does ADE apply to this situation? Antibody dependent enhancement.
Yeah. First, I mean, I like the ADE story because, you know, we are people who are dealing, the doctors who are doing tropical disease, we are living with the ADE because of the dengue, etc. And I think nobody else knew about ADE, neither doctors specific nor lay people. And now everybody is familiar with ADE. It's become kind of a cup of tea, of a daily cup of tea. So again, I mean, there was a fear that maybe the vaccine will cause ADE. So far, you know, 100 million of people got it, and we don't have any hint for having ADE from the vaccine. And the other question is, we saw patients who become sick few days after the vaccine. And then, you know, all the thought may come that maybe the vaccine somehow enhance the situation. The only way maybe of enhancing the situation is actually when you have a big centers of vaccination and many people coming to attend the vaccine, and there's no distancing. You may contract the disease due to this crowdness around the vaccine center, but not because of the vaccine itself.
Got it. So I'm sorry, I'm pushing ahead with the questions. I know time, I'm very much aware of it. I'll stop in a few minutes. Paul Bork says, thanks for such a good, rigorous study. Well done. So that's actually a comment to your study. Ease Joy Exuberant says, is it safe to continue taking ivermectin monthly, day 1, day 4, if body temperature has dropped and is now consistently 97 degrees?
I'm not sure about the disease, but if the question is that if somebody got corona with fever and now the fever is down to normal, I don't think he has to continue the ivermectin.
Agreed. Colin Hamill says, if you worry about variants and think they may have to change the vaccination to suit, why not just stick to ivermectin?
So again, as I mentioned before, I'm not that worried about the variants, but one of the points that everybody can say that better to have ivermectin in our back in case something happened to the vaccine, it's failed, and we're going to prove that ivermectin can be a prophylactic drug, then we have another method to protect ourselves.
Totally makes sense. And similar question here from Dr. Amir Hashmi, does ivermectin work for variants?
So again, so far we know it works. It works in the lab and works in life, and I hope it will cover all kind of variants.
Totally agreed. And the ivermectin mechanism of action is just like Professor Schwartz talked about molnupiravir from Merck, which is our DRP disruptor. Ivermectin is our DRP disruptor. It is 3-chymotrypsin-like protease disruptor. It is disruptor for alpha, the important alpha and beta. In silico studies have shown that it kind of disrupts the ACE2 binding of the spike protein as well. Plus it modulates nuclear factor kappa B. None of them are affected by variants too much. So in general, it should work.
Actually, this is the advantage of drug, that they are not affected by the variants.
Correct. So let's do one last question. Couple of last questions, if you're okay. So here two last questions. So Sunshine Bean says, what is the timeline for myocarditis after messenger RNA vaccine? For example, after how many weeks are you out of the risk? This may be someone who is taken the vaccine and now worried.
So, I mean, the experience, as I mentioned to you, it's usually young males, and it's happened after second vaccine and usually after 3-4 days after the second dose.
Got it. And the last question, Romana Belkova Graham says, I am wondering if messenger RNA is not a slippery slope. I prefer the immune system to be exposed to the inactivated pathogen subunits and create its own reaction rather than being genetically instructed. Is there no concern that overriding instructions would cause autoimmune issues in long term?
So again, I don't think there's a problem. And again, genetically modified vaccines, we have it for years now. For example, take hepatitis B, which is a international, it's a global vaccine, and children get it since birth. They're getting for 30 years, and we don't have any problem. So actually, all vaccines finally do the same, and I think the mRNA probably does it in the best way.
And
most efficient, quick and efficient.
Absolutely. And if I can just add this as well, that Romana, it seems from your question that you feel that somehow RNA instruction is to make antibodies. That is not the case. This RNA is going to make. Dr. Schwartz, thank you so very much for being with us. At this time, it is now later than 10 at your place. It's in the evening. Thank you for the discussion. Thank you for the insights. Thank you for being with us.
Good night or good afternoon or good morning for everybody. And it was very nice being with you. Thanks for invitation.
Thank you.